Hey everyone, thank you so much for being here and welcome to my presentation. I acknowledge all the nurses, my colleagues, the doctors, clinic leaders, professors, grant reviewers, and all the patient advocates that are here. I hope you enjoy this presentation. My name is Hendry Yuma, and I'm really excited to share a simple idea that grew out of caring for people between visits. This proposed research study is entitled Efficacy of Structured Weekly Telephone Outreach on Medication Adherence in Hypertension Management. All it takes is a quick weekly call from a familiar voice to help someone stay on track with their medicine and feel supported. I can't wait to show you how a small gesture like this can make a big difference in our patients' lives and in our work together. Recent studies showed millions of adults in their 30s and 40s struggle with hypertension, not because treatment is complex, but because they miss doses, forgetfulness, side effect fears, and medication costs derail even the most motivated patients. So when pills are skipped, blood pressure stays uncontrolled, and the risk of heart disease, stroke, and kidney failure climbs. Yet, the standard clinic visits every few months leave too much room for doubts and distractions. This study proposes a simple but powerful solution: a brief, weekly phone calls that offer reminders, education, and a safe space for patients to raise concerns. By comparing these regular check-ins with the usual 3-month follow-up schedule, we aim to see whether a friendly voice can help adults protect their health one call at a time. In this study, I chose a research question over a hypothesis in order to explore real-world feasibility and generate actionable insights. The question goes this way: in 30 to 50-year-old patients with hypertension, how do weekly phone call follow-ups versus the standard 3-month follow-ups affect medication adherence and blood pressure control over a 1-year time frame? So, if we dissect our pie cut question, it'll go this way. The P is adults aged 30 to 50 with hypertension. The intervention is weekly phone call follow-ups. It will be compared with the standard 3-month follow-ups. The O is medication adherence and blood pressure control, and the time is 12 months. Silent hypertension quietly chips away at health, often unchecked due to missed doses, fears of side effects, or cost barriers. Ryan et al. 2022 emphasized that non-adherence isn't just forgetfulness. It's a complex blend of personal and systemic hurdles. They called for empathy and structured support. Community pharmacists have shown promise, especially in Spain, where Torres Robles et al. 2022 ran a landmark trial. Patients who received tailored pharmacist-led education and follow-ups improved their medication adherence and blood pressure. Across the globe, Kim et al. 2025 reinforced this trend. Each bump in adherence lowered emergency visits and blood pressure rates. Rural studies like Zhang et al. 2024 added another layer, showing how patient-family partnerships further strengthen adherence, but we're not going to focus on this. Nurse practitioners, as highlighted by Brownwood and LaFortune 2024, are uniquely equipped to lead such efforts. Their blend of clinical skill and patient rapport positions them to streamline care, offer counseling, and engage patients consistently. So nurse practitioners really have the edge to do this. But still, gaps remain, especially for the busy adults in their 30s to 50s. We are also guilty with it because we're on that age. This study proposes a new model, just a simple weekly check-ins led by the nurse practitioners, measuring adherence, blood pressure, and quality of life over a year. Because small, consistent touches may turn silent risk into sustained wellness. Dorothy Orm's self-care deficit nursing theory anchors this research. It asserts that individuals can care for themselves, but when they can't, nurses step in to bridge the gap. The theory has three parts: self-care, self-care deficit, and nursing systems. So, in managing chronic conditions like hypertension, especially hypertension, this model fits perfectly. Weekly phone call follow-ups serve as a supportive educative system where the nurse practitioners guide the patients to build confidence, knowledge, and routine around their medication and blood pressure control. And the evidence backs it up, of course. Nasribet et al. 2021 found that applying Orm's theory significantly improved adherence in hypertensive patients. It is a powerful framework for empowering self-care in a real-world practice. For our population, we will include all those who are aged 30 to 50, diagnosed with hypertension for over 6 months, the ones who has stable antihypertensive regimen, the ones who has reliable phone access, and of course fluent with English. We will exclude all those who have cognitive and psychiatric conditions affecting consent, and those who are pregnant and has a secondary hypertension. For our setting, we will get a sample of 100 from a South Georgia primary health clinic. We will use purposive sampling. So the weekly calls will be delivered through a HIPAA compliant telehealth platform. For our ethical considerations, we'll make sure that we have an informed consent, that we explain all the purpose, procedures, and we will tell them their rights. Voluntary participation with no impact on standard care, confidentiality, secure platform for call notes and blood pressure logs, minimizing their burdens, no change to the prescribed therapy, and we will at least try to find an alternative contact methods for those with limited phone or internet access. But as I've said in the previous slide, we will prioritize those who has a reliable phone. According to Georgia Southwestern University website, there are three IRB review types: full review, expedited, and exemption. So about this study, weekly phone call outreach poses minimal risk and no invasive procedures. This study aims to obtain exemption status based on educational and behavioral focus. Exemption expedites approval while ensuring ethical oversight. This study uses quantitative experimental design, a two-arm randomized controlled trial to compare two care models in adults aged 30 to 50 with hypertension. Participants are randomly assigned to the control group, which receives standard 3-month clinic visits, or to the intervention group, which receives weekly phone call check-ins from an advanced practice nurse or care coordinator. Randomization balances confounding factors and allows us to test causality between enhanced follow-up and changes in medication adherence and blood pressure control. Over the course of 1 year, we will track adherence metrics alongside blood pressure readings to determine the impact of weekly outreach. The findings will provide numerical evidence to inform evidence-based recommendations for hypertension management. For our statistical analysis plan, we will follow an intention to treat framework running analysis in SPSS with an alpha of 0.05. First, we'll describe our sample, the continuous measures like age, baseline, blood pressure, MMAS, 8 adherence scores. All those are means with standard deviations. And then the categorical variables such as sex, adherence category, as counts and percentages. So the baseline group comparability will be checked using t-tests for continuous data and chi-square tests for categorical data. Our primary outcomes, which are the changes in systolic and diastolic blood pressure for over 12 months, will be analyzed with repeated measures ANOVA, or the analysis of the variance, switching to linear mixed models if assumptions fail or data are missing. For medication adherence, we'll compare the MMAS-8 scores between groups with a t-test, contrast adherence rates with via chi-square, and if available, plot time to non-adherence with Kaplan-Meier curves and the log-rank test. We will build regression models to adjust for age, sex, baseline, blood pressure, and comorbidities using linear regression for blood pressure change and logistic regression for binary adherence outcome. To handle the missing data, which is inevitable, we'll assess the mechanism and then apply multiple imputation across 10 data assets and validate findings against the complete case analysis. All results will be presented in clear tables, figures, or some graphs to highlight both statistical significance and the real-world impact of our weekly phone call intervention. We will make it very, very simple so that everybody could relate and understand. Every research study needs some money to move, so I'm here to discuss the funding strategies right now. Our anticipated costs are the salary for the research staff, which would include the research assistants and telehealth nurse, the money for the technology to secure the phone service, data platform, SPSS license, and the Mariski medication adherence questionnaire license. We will also need some money for the IRB fees, training, and educational materials, and money for the incentives for the participants, because we will give $50 upon enrollment, $50 after 6 months for retention, and $50 when they finish their research and their participation. So thank you, American Heart Association, Agency for Healthcare Research and Quality, and Center for Health and Justice for coming over today to listen. I believe American Heart Association fits perfect for this study because they are concerned about cardiovascular and behavioral goals. And the Agency for Healthcare Research and Quality focuses on improving healthcare delivery and patient safety. And of course, the Center for Health and Justice, which supports equity-driven community programs. So in advance, I'm very thankful for your support. In summary, medication non-adherence in adults aged 30 to 50 is a silent crisis. They skip or they stop their blood pressure pills, and for some, it's just simple forgetfulness. For others, it's the cost or the fear of side effects. Uncontrolled hypertension badly affects the heart and kidneys. It could raise a stroke risk. And of course, it drives up emergency visits and hospital stays. Previous efforts like the pharmacist-led education and follow-up calls, rural family partnerships, and structured check-ins, they all have shown promise but still miss the mark for busy younger adults. Nurse practitioners, though, with both prescriptive authority and strong patient rapport, can close this gap. I strongly believe on that. Weekly phone calls become personal touchpoints where missed refills get flagged, side effects, worries are eased, and self-care habits take root under RM's self-care deficit framework. A structured outreach led by APRNs or some small care team isn't magic. It's gonna be a phone call with concern that could transform silent hypertension into a story of steady progress. I know this will greatly impact the healthcare industry, and I truly believe in this. Thank you. I thank you all for sharing your time to listen to this research proposal, which is very important to me. I appreciate everybody. I hope you have a great day, and feel free to reach out if you have any questions or clarifications. Have a good one.